group Age and Health. Yannis is the chair of the second department of the Hellenic Imperium Center in Athens. And he's going to talk about the changes of body composition following spinal cord injury. Yannis, please.
Thank you, Annie. Dear colleagues, good afternoon. It's my pleasure to be here, and I would like to thank both societies for the kind invitation. Paralysis and loss of function that usually occur in well-documented hypercatabolic responses may lead to deleterious effects such as loss of lean mass and obesity. Unwanted weight gain should be prevented because it induces the risk for diseases such as diabetes, coronary heart disease, and dyslipidemias to occur prematurely and at a higher prevalence in this population. And of course, body fat has been identified as a significant predictor of mortality. So in these persons, muscles lose strength, lean muscle mass is lost and is replaced with adipose tissue, and eventually a slender athletic build gives way to one that is overweight, with individuals developing a protruding abdomen and a somewhat stooped posture. Body composition markedly deteriorates during the first 6 months after the injury. The total body lean mass decreases as much as 9.5% by 6 months post-injury, whereas leg lean tissue mass decreases 15.1% by 1 year post-injury. In this slide, you can see the pathophysiology of muscle loss. But this muscle loss below the level of injury is much greater compared with other conditions like age, immobilization, bed rest, or even lack of gravity environment. And as you can see here, the nervation may be a reason, but also the decreased hormonal synthesis, fat deposition, protein degradation, macrophage phenotype switch, insulin resistance, muscle fiber conversion, and even apoptosis. Moreover, there is a dual action of paraplegia in the muscle with disuse, which is leading in myopathic changes and reduced satellite cells and myotubes, which are important for muscles, but also spasticity is leading to fiber type transformation. And in this population, we are finding more fast type 2 fiber. I admit that we published a very difficult slide here, a very difficult picture in this publication, but we can see on here that due to increase of prostaglandins, we have increased arachidonic acid and increased fat in this population, and moreover, lipogenesis is also increased. And that is making a new entity, the so-called sarcopenic obesity, because we have the secondary sarcopenia due to muscle loss and the obesity. So this complex interplay of common pathophysiological mechanisms such as pro-inflammatory cytokines, oxidative stress, insulin resistance, hormonal perturbations, and decreased physical activity, and underlies a close relationship. And this vicious cycle may amplify concomitant accumulation of adipose tissue and loss of skeletal muscle mass. Coming now to bone loss, another multifactorial pathophysiology, very complicated in the acute and chronic phase. The nervation, of course, unloading on the other side, the hormonal changes with increased glucocorticosteroids, leptin, the reduce of hormones such as IGF-1, the sex hormones, vitamin D deficiency, calcium decreased calcium absorption, and more, all this lead to increased bone resorption. Bone loss below the level of injury, exactly as muscle, is much greater as other compared to other conditions. And during the first year, we observe a rapid decrease, calculated about 4% in regions rich in trabecular bone, such as the tibial and femoral diaphysis, and about 2% in regions with particularly compact bone. This is what we get from the PQCT, the peripheral computed tomography of the tibia in a paraplegic person. You see, all this area is infiltrated with fat. It should be red, but it's fat inside. No more bone. And this is the cortical bone, which is now thin. Tomorrow in the workshop, I will give you more details about it. And of course, someday this stops. There is a new steady state in the paralysis, which is different regarding the bone and regarding the area. Now coming to the assessment of bone and muscle and fat. In spinal cord injury subjects, it can be assessed with various measures, techniques. In the old times, they used the isotope labeled water with total body potassium. We can use anthropometric measures. We can use BIA, and we can use also DEXA. However, some of these methods are not particularly suitable for use in SCI population. Coming first to the anthropometric measurements. This publication presented nice data regarding measurements and concluded that the authors concluded that anthropometric indices may be valid proxy measures to estimate obesity in males living with SCI, and waist circumference was also promising measurement. However, there were the authors found problems with BMI. A few years ago, I published a review, more than 15 years ago, regarding malnutrition. This is a different situation here in this population, because anthropometric standards such as ideal body weight, skin fold thickness, middle arm perimeter, that are common tools for assessing nutrition, cannot be applied to these people due to changes in fluids, muscle atrophy due to mobility and denervation, and increased body fat. And premature weight loss of these subjects is mainly due to the loss of muscle, not fat, which affects the validity of the results. And we proved that doing a comparison of able-bodied and paraplegic subjects, and you see that for the same values of BMI, we found increased values of total fat mass. So BMI is not a good kind of measurement for these subjects. Coming now to bioelectrical impedance analysis, which is easy and is very often used. This device measures the impedance to the flow of the electrical current to estimate body composition, where higher or greater electrical impedance is correlated with higher fat mass. And we receive some equations to assume proper infiltration and fluid distribution. That means that we make two assumptions. The BIA equation follow certain assumptions related to proper iteration and fluid distribution. One equation may be valid. This from Cochin and Hayward, and is validated in spinal cord injury individuals compared to fat-free mass obtained using DEXA. So it is good to use it. On the other side, the inclusion of weight in the BIA predictive equation may reduce its accuracy in determining change in lean body mass. BIA method is almost impossible to measure accurately height in subjects with spinal cord injury because of their muscle contractures. And an overestimation of height, for example, by 2.5 centimeters can result in big mistakes. Another major problem is body asymmetry, which renders the assumption of a symmetrical configuration of the human body invalid in this case. Coming now to DEXA, which is a 3-compartment model compared to BIA, which is a 2-compartment model. Because with DEXA, we can measure good bone, soft tissue, which includes fat mass and lean mass, meaning the bone-free, fat-free mass. So DEXA measurements are also based in an assumption that the duration of fat-free mass remains constant at 73%. However, this is wrong because this can vary from 67 to 85 and can vary from disease state, like, for example, in spinal cord injury. However, DEXA technology has been adapted for the assessment of whole body composition and is used because it's rapidly, it's non-invasively, and with minimal radiation exposure, only 1 milliwatt. DEXA is not dependent on other measurements. An agreement between the weight calculated by DEXA and actual weight is excellent. So we have two indirect methods, DEXA versus the double indirect method BIA. At least one assumption we rely on and versus two assumptions we rely on. The more assumption, the less the accuracy. We must realize that. These are the pictures we get from whole body DEXA, and you see in the upper picture is the able body subject, and you see in the NORLAT device how we can see a paraplegic subject. And DEXA is also good because it gives nice reports with nice indices which can use, like the one of skeletal muscle mass index is the main index we use in sarcopenia to get results, and we need the results to make statistical significant results, to make research. That is very good for using this kind of devices. DEXA gives also the possibility to calculate the fat mass index and the similar index for fat, and this is very useful. So we used DEXA to find the threshold for sarcopenia in spinal cord injury subjects, and we find that persons with SMI, this index below 5.28, were classified as sarcopenic. On the other side, when all these subjects are in the hospital or are hospitalized or come to the outpatient clinic, we need an assessment. And the only assessment I believe is validated and it's good for rehabilitation is the short nutritional assessment questionnaire. I'm not saying I will not expand my discussion on this because I have limited time, but please remind you to use this questionnaire, which is validated. It is very good to assess body composition in obesity. Now, should we give calcium to prevent and treat these subjects? Of course, we need calcium. Of course, the basic therapy includes the administration of calcium, and intake of 1,000 milligrams daily is recommended. But the conventional diet is generally considered insufficient, and that's why we need to provide maybe supplements. About vitamin D. Vitamin D is also very important. At least 800 to 1,000 international units per day are vital for these subjects. And the optimal value for vitamin D for this subject is 30 nanogram per ml. That is the optimal value. It's a little bit higher from the normal population. Regarding drugs, of course, we can give drugs for bones. We know that from osteoporosis field. Bisphosphonates are very common used. However, we now have other weapons, more modern weapons, like the denosumab, which shows that this drug increases sublesional bone mass in osteoporotic individuals. And we need to learn to use this drug also. It is a subcutaneous injection in the abdomen area every 6 months. And of course, not to forget to give hyperprotein supplements to this subject because they lack of protein and they need protein for the muscle system, to stabilize the muscle system. Therefore, an objective should be the maintenance of optimal nutritional status of the patient to supplement the deficiency in nutrients. An optimal nutrition assessment and management can be minimized all these complications like obesity, loss of muscles. Coming now to non-pharmacological approaches. Okay, we cannot use the exercise program we use in the rest rehabilitation population. However, we can use what we have. What we have is standing. We can use possible walking with orthosis. We can use functional electrostimulation, very useful, or cycling even. We can use sometimes vibration, but this is research, and we also use pulse electromagnetic fields. All this will help to improve body composition. And this is my last slide, and I believe my last slide and my message is that, as we can see, as we learned that at the first months, muscular atrophy reaches the steady state, as bone does also, which is likely maintained by reflexive activity of lower motor neuron. A long-term maintenance of functional structural muscle properties suggests that treatment can begin at any time after the injury in these patients, possibly with the same or similar efficacy. And even during the late stage of upper motor neuron injuries, such as spinal cord injury, for example, there are no deadlines, at least up to 20 years, to successfully launch a rehabilitation program using, in example, functional stimulation. So we don't need to forget these subjects. Thank you for your attention.
Thank you so much, Yannis, for saving us some time for questions. I appreciate this. So you are now ready.